Hi, everybody, and welcome to Biotensegrity party number 35, if you can believe it. We're going to be doing today another one of Niall Galloway's series on anatomy and movement. And today we're going to be focusing on the pelvis. So I want to say hello. I'm in Washington, D.C., and I want to say hi to my co-host, Chris Clancy. Hi, Chris, in Deep Cove.
Hi, Susan.
And Graham Scar. I'm always looking in the gallery view for everybody, and I guess I don't need to do that. Graham in Nottingham. Hey, Graham.
Hello, Susan, everybody.
And we've got our wonderful sort of assistant co-host type people who always step up to the plate. Rachel Tudor. Hi, Rachel.
Hi, Susan. Hi, everyone.
Rachel's in Tumwater. Lisa Babiak. Hi, Lisa.
Hi, everybody.
Lisa's up in St. Albert, where the bears are. And Mariana Barreto. Hi, Mariana.
Hello, everyone.
And Mariana's in
Mississauga. Mississauga, near Toronto in Canada.
Mississauga. Why do I have trouble with that? Near Toronto. Thank you. And our special host today is Niall Galloway. He's in Atlanta. Hey, Neil.
Hello.
And then presenting today, we have Anna Crowle. Anna, where are you?
I'm in Leeds, in Yorkshire, England.
In Leeds. Wonderful. Anna's a physiotherapist who specializes in applying biotensegrity concepts to her work with pelvic organ prolapse. And we're also going to hear today from Dr. Stephen M. Levin. Hey, Steve.
Hi, all.
All right. So I'm going to just turn it over to, and hello and welcome to everybody. It's so great to see these faces. I'm going to turn it over to Anna for the opening toast.
Hi. Well, I've got to say it's such an honor to be able to take part in this, and I've just been loving these tea parties. It just feels like such a wonderful community, and there's so much connection, and it just feels like such a wonderful place to be able to share. So community and connection.
Cheers.
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 Hey, Gumbe. Anna, you have to tell them about your mug.
My lovely mug, my Bristol stool chart mug with all the different types of poo that you can have on your mug that my lovely husband got me for Christmas. So when I'm talking to my patients and they're talking to me about their constipation, I can say, well, you know, where are you on this chart? What sort of poo do you have? Lots of talk about poo in my clinic group.
We love it. We love it. Graham, I'm going to send it over to you now for the sponsors.
Hi, thanks, Susan. Yes, our Biotensegrity party is an all-volunteer production of the Stephen M. Levin Biotensegrity Archive, and made possible in part through the generous support of our wonderful sponsors. Starting with Handspring Publishing in Scotland, have a wide range of authors and books suitable for the manual therapist and movement professional. They are offering a generous discount coupon to all those on the Biotensegrity Archive mailing list and our Zoom participants. Handspring also produce a newsletter entitled Springboard, which you can join from their website, handspring.com. And it provides details of their webinar series, Move to Learn, hosted by Elizabeth Larkham. We are also generously supported by Chris Clancy's educational organisation, Embodied Biotensegrity, in Vancouver, British Columbia, and which provides an excellent resource for those of you looking to learn more about biotensegrity. Chris has several different courses on the go, so take a look at those. The Biotensegrity party is also sponsored by Artifact Pro of Madrid, Spain, where you can find wonderful anatomical tensegrity models to interest yourself and your patients and others too. And Artifact Pro also offers a generous discount coupon to our Zoom participants. We're also kindly supported by the Fascia Hub, thefasciahub.com, and which starts with a full day of talks on the fascial pelvis, on Saturday, the 28th of November, which is next week. So register soon for a full day of talks with many different speakers. And we also have Integrated Biotensegrity, which is Licia Babiuk's organization based in Alberta, Canada. A one-day course from early November with Lisa Babiuk, Paul Thornley and Rachel Tudor is now available as a recording, and details will be in the chat once more. And finally, Anna Crowle, who is presenting with us tonight, has a course available on pelvic organ prolapse, and for all those interested in learning more about that, and there'll be details of that in the chat, and I think she will talk about it soon during the session. Okay, back to you, Susan.
Thanks, Graham. So if you're paying attention, right, you're actually getting between today's event, right, and then if you do the event that the Fascia Hub has coming up, you'll have this like a fabulous mini course on biotensegrity in the pelvis, and Neil's going to be part of that Fascia Hub event as well, and John Sharkey is. John, you want to give a wave? And I think everybody already knows you, but it's always nice to have you give a wave. So anyway, with all of that, thank you everyone for being here, and I'm going to pass it over to Neil.
Well, thank you very much, Susan. It's very nice to be here. It's a thrill to have Anna on the show today, and she's going to talk to us a little bit about her treatment strategies for dealing with problems in the pelvis. We're also going to hear from Steve Levin, and Steve's going to talk to us a little bit about his experience with the pelvis. Steve, would you like to go first?
I'm going to interrupt. I should have said, because we've got some first timers here. At this point, everybody turns their camera off if they're not one of the main presenters for the day, and then it looks better on YouTube. So thank you for turning your camera off. Thanks for the interruption.
Good idea.
No, actually, what I'm going to be talking about is the pelvis from the standpoint of back pain. And I think you really, right now, the focus should be on the gynecologic and visceral aspect of it. So I'll just throw that in later.
There we are. Well, that sounds very reasonable. And it's also appropriate to let ladies go first. So let me invite Anna to start the show. Thank you very much, Anna.
Hi, thanks for having me. So I'm Anna. I'm a women's health physiotherapist. I'm also a myofascial release practitioner, and I had a paper published right at the beginning of 2020, end of 2019, that was putting forward this concept that pelvic organ prolapse is due to tension within the pelvis rather than a weakness and a laxity. And I've got a second follow-up paper that's now out for peer review. So my work centers around looking for and treating with physiotherapy techniques tension within the pelvic structures. So in mainstream gynecology and women's health physiotherapy, a continuous compression model of understanding prolapse persists. And Neil, I know that you've been doing a lot of stuff around putting the Biotensegrity model forward to the surgical community. So my focus is on what can be done within physiotherapy. And we had another discussion prior to this, didn't we, about the naming of structures. So the pelvic floor is what is commonly called those structures within the pelvis, but we had a little conversation beforehand about pelvic outlet, pelvic diaphragm, and there's other terms. So for now, it might be a little bit interchangeable between them. Okay, so in traditional mainstream continuous compression women's health physiotherapy, the ship in the dock theory is usually used to describe what happens with prolapse. So that is basically that the organs are supported from below with this structure commonly called the pelvic floor and above by ligaments. within that theory, the floor is working constantly to hold the vagina closed, offering an upward support. Then when there's weakness within that floor, strain within the ligaments happens, and then down the organs come, okay? So particularly in the UK, the main physiotherapy input for prolapse is often Kegels, so pelvic squeezing exercises, and the objective there is to build up this bulk in the muscle to offer upward support. But that is just not in keeping with biotensegrity principles. There's this sort of approach within that continuous compression world to say that a tight vagina is optimal, that a tight pelvic floor, a tight vagina is what's needed in order to hold up the organs from below. But actually, I really feel like that is steeped in misogyny, because a tight perineum and a tight vagina is just not optimal for female pelvic health at all. Actually, these structures are highly mobile and dynamic, built for stretch, elasticity, recoil, and dynamism. So healthy pelvic structures need to soften to allow for bladder filling, relax to defecate. They unfold and unfurl for normal movement, and of course lengthen up to 3 times their resting length to accommodate childbirth. So the area of the pelvis that's kind of just here inside the sit bones, this is really crunched up. It's really folds upon folds upon folds upon folds, and this is how it has such a capacity for lengthening for childbirth. But actually that lengthening happens just with walking. Those tissues uncurl and unfurl, or with sitting or squatting. This tissue right inside the sit bones uncurls and unfurls, and that's something I'll come back to in a little bit. So the levator ani, or what's been commonly called the pelvic floor muscles, is a sort of funnel or bowl shaped, which is able to open to accommodate the passage of a baby and then recoil back. And for me, the most interesting thing about the vagina in childbirth is not how it opens. It does this through this uncurling and unfurling of that tissue right at the entrance. But I think it's the incredible capacity for recoil. We can birth our babies open completely and then within minutes stand up, walk around and carry our child. That is incredible. And the only way that that can happen is through biotensegrity, through the expansion, repositioning and contraction of tensegrities. And it's happening right there at what I'll call the crowning point. So this point where the vagina becomes the perineum and the vulva. So it's this area here. So if this is the perineum, this is the left, this is the right, and it's here where we have this real capacity for crowning, which is the baby's head meeting the perineum. Okay, so normal, uncomplicated childbirth is what the vagina is designed to do, but often problems arise where there is obstetric trauma. So that's things like episiotomies, which is a cut to the pelvic floor, pelvic structures, or birth-related tearing. And depending on what's happened with that particular birth, there's different degrees of damage and then different degrees of scarring. Numerous factors come into that, which I can talk about in a bit. So at the moment in mainstream women's health physiotherapy, particularly in the UK, I don't know so much about in the other places, but the main treatment that's given for this type of injury is this repeated pelvic floor squeezing. Okay, so this is sadly actually quite a weak evidence base. We have some studies, but really it only shows, you know, a tiny little change for a few women that only lasts a short time. And quite upsettingly, a lot of women report that that actually makes their symptoms worse. Their symptoms such as dragging, bulging, heaviness, difficulty defecating and difficulty urinating can actually be made worse by doing lots of this squeezing. And really that strength training approach is to hold the vagina closed in standing to hold up the organs from below, which is just not right. It's just not based on biotensegrity concepts. It's quite an out-of-date concept, and women just don't hold their vaginas closed in standing. They just don't. So I believe that rather than muscle bulk, what we need in those pelvic structures is elasticity, dynamism, and the ability to stretch and recoil with ease. So I've been using an alternative approach. using primarily palpation of the perineum and the internal pelvic muscles, the levator and the fascia, to find areas of excessive tension and look at how they relate to a disruption in organ position. So pelvic organ prolapse is a disruption in organ position. So the old way, the continuous compression model, says that the bladder or rectum fell into the vaginal space, but as we all know, that's not how the body works. So what I've found is some patterns of tension which have become quite predictable. There's certain patterns of tension happening within the pelvic structures which happen for the different types of prolapse. So primarily, the different types of prolapse are a rectocele, so a prolapse of the rectum into the vaginal space, a cystocele, that's a prolapse of the bladder into the vaginal space, and an apical or cervical prolapse, which is the cervix coming down. So if it's okay, I'm going to show you these tension patterns through movement, because I can't find a model which shows this. So I'm just going to show you it with myself. Okay. So imagine I'm a rectum down the back of the pelvis, okay? And this is the pelvic bowl, the inside of the pelvic bowl. So that's the levator muscles, okay? And also the tala, the tendinous arch of levator, big fascial structure, runs from the front, runs from the back up to the front, okay? So rectum coming down the back, levator and tala like this. And then we've also got the aftup, so the arcus fascia tendinous pelvis, which is like a roof within the pelvis, okay? And within that sits the cervix embedded like a chimney, which is obviously part of the uterus, okay? So, and here's the bladder. It's got its nice, comfortable home above the pubic bone, a little bit of wiggle room, plenty of dynamism, but basically it's home there. So, when you add tension into the mix, say an episiotomy scar, bang, down the inside of the right-hand side for the episiotomies, tears, you know, different patterns for different injuries. So, say you've got an episiotomy coming down here. So what that's going to do is pull on the nearby soft structures. So what happens if that tension lies near the rectum is that, okay? So the rectum literally gets disrupted in shape. And so this formation of a bulge here within the vaginal space, and so that real difficulty getting the poos out, which is what happens with a rectocele. It's incomplete emptying of stool. So the stool comes down and it's just stuck there. So that's a rectocele. Okay, so with a cystocele, so there's the bladder in its nice but dynamic home just here. So what happens there is that the tension, again, it's going to be here or here, but say it's here, and it pulls around the tala. For the cystoceles, it pulls round the tala until the position of the bladder gets disrupted and disrupted and disrupted enough until it's there, a bulge inside the front of the vaginal space with all of the difficulties emptying the bladder that come with a cystocele. Okay, and for the apical prolapses, for the cervixes, what happens is this aftup, it's this that gets pulled on. So here, the tension seems to come up the side of the pelvis, pulling that cervix over and over and over and over until down it is low in the pelvis with that deep dragging sensation, which is absolutely concurrent with what women feel with that prolapse. So the other thing that I feel is really important that's come from this work of trying to map these tensions is that so much of it is this rim, this point where the perineum and the vulva become the vagina, which is puborectalis is the majority of what, so there's other small ones, but puborectalis. And this is where these folds upon folds upon folds upon folds, which allow this crowning motion, okay? And here, where tension builds up here, adhesions, often scars, that is what seems to leave women most vulnerable to this disruption in organ arrangement, okay? And again, if you look on me, so this motion, so when the puborectalis does this, okay, so when the puborectalis is it has its maximum length, so that's that crowning motion. So what happens, that the range of motion there is that, okay, so that's that range of motion happening within the pelvis. So when that gets restricted, if you're not trying to pass a baby down there at that particular moment, you might not know that that's restricted unless it's giving off symptoms. So that's the range of motion. So when that's restricted, what you get is this down drag here. That's that back pain, that's that deep hip pain, that's that down drag on the organs here. Yeah, it's because of all the restrictions happening here. It literally pulls everything. Backache, hip ache, organs descending. Okay. So, oh, another thing. So I've explained where the bulging comes from and where the dragging comes from, and those symptoms, those difficulties defecating and urinating. But the heaviness is a feature as well for a lot of women. And actually, that is just the tight tissue. So when that tissue is released, that heaviness sensation just lifts. So basically, it's tension in different areas of the pelvis, which play out in different ways and then disrupt the arrangement of the organs. But we can basically just release that tension and then the organs go home, because that's the nature of biotensegrity. The organ position becomes disrupted due to these pulls. You find the pull, you release the pull, and back she goes. So, and like all myofascial release work, you know, these changes are immediate and profound. You know, like all fascial bodywork, the structural change can happen with just a few minutes of release in the right place. And then these changes last, you know, so I can go in and palpate the tissue, find where the patterns of tension are, release them just using straightforward myofascial release. The tissue releases, these folds and unfolds, this curling and uncurling, all this tissue, the shape change, and then the organs go back. So for the bladder and the cervix, the organs go back home, and for the rectum, it's a shape change. That, because I think this is just because the rectum is a softer thing. So when the rectum gets pulled on, it forms a bulge, whereas when the bladder gets pulled on, the whole thing shifts. So with that releasing of the tension, that pocketing that's formed in the rectum becomes smaller and smaller and smaller and smaller and smaller, reducing her symptoms. Or for the bladder and the cervix, you can literally just send her home by releasing what is pulling on her. So also the earliest times I was doing this was 2015. And because I've been trying to put these papers out as well, I've followed up all of those early patients and they are all still good. So this lasts. And it's really a beautiful thing watching this change happen like this. We've been measuring the success of this using the PFDI 20, which is a validated questionnaire. So bear in mind that the treatment that I'm trying to compare this with is this squeezing, because that's the other that's the classic physiotherapy approach. So I've got a couple of studies that used pelvic squeezing to try to treat prolapse using the same measure. So they found a 3% improvement in symptoms using squeezing for prolapse, and the other study found a 9% improvement in symptoms by using pelvic floor squeezing for prolapse. And this method, we're looking at around a 50, so 50. So it is significantly better. And really, I think we've got a lot of issues around, again, it's this misogyny basically of women being told your bladder is falling out of you. So what you need to do is grip and hold it back in. And obviously, if you're going to be told that your organs are falling out of yourself, your unconscious behavior is then to do this, which actually makes everything worse, because actually what we need to do is release all the tension to restore the normal dynamic equilibrium. Is that okay?
It's awesome, Anna. Sorry, Neil, I jumped in, but listening to you is blowing me away, because this is my experience through yoga practice and the practice of Mula Bandha, how people way overdid it. But I'm going to let Neil take over. Sorry, Neil.
No, I'm going to interrupt too. This is Susan, and Anna's like, is this okay? Anna, you have to see the chat, because people are going like ballistically with enthusiasm, just one comment after another.
Cool.
Well, that was very good, Anna. Thank you very much. Also rather balletic. How do you
Models, I can't make a model that shows that. In the end, I've given up.
How do you think the excessive tension builds up in the pelvic floor? What's your thoughts?
I've mentioned, well, whatever we're going to call it, the pelvic floor or pelvic structures. So I really do feel like the scar tissue is a major player. So not all prolapse is due to those scars. Some women have prolapse that have never had children. Some women have prolapse that have never had scars. However, 90% of women that have had vaginal deliveries have some degree of scarring in their pelvic floors, pelvic structures, okay? And bear in mind that pelvic organ prolapse affects half of women at some point. This is huge numbers. And in my recent paper, out of the 33 women, the one that's still out for peer review, out of the 33 women that we treated, 85% of them had scars that were taking a role in this displacement of the organ arrangement, because we know that scar tissue, we know that scars don't do this. So we know that scarring gathers up the tissue and causes this three-dimensional pull through the system. And increasingly, we've got more recognition of what's happening with C-section scars and how that disrupts what's happening abdominally. And 90% of women who've had a vaginal delivery have got some degree of scar tissue that runs right through here and here. So this area, I really feel like the scarring is a major player that we can just talk more about and treat, you know, collectively, whatever our background.
I think we have two different audiences here, two different sorts of communities and conversation. One has to do with the surgeon and the anatomy and pelvic organ prolapse. And there the focus tends to be on measuring the prolapse itself. And there's also with this a functional aspect that has to do with symptoms. And your approach to this has been to treat the symptoms and to demonstrate improvement in symptoms. Is it true also that you've also been able to demonstrate any anatomical change in the severity or degree of the prolapse?
Yeah, it's anatomical change. So what I've been able to measure in a validated way is the symptoms, because I've got that PFDI 20. So the anatomical change is happening, but up to this point, I've not managed to basically in a trial, which is what we'll do next, we're going to ask somebody, a gynecologist, to do pre and post measurement. So what I've done in my papers, measurement of the descent of the organ. So this is another thing that I feel is, there's the two different schools of thought. So if we're measuring how far has the bladder or rectum descended down, so the POP-Q score and the Baden-Walker score are the classic scores that are used to measure how far down the vagina the organ has descended. But we know there's loads of misnomers in that. Like, we know in the evidence that people can have hugely symptomatic cystoceles that only ever measure as a mild descent. And actually, I think that's because we're measuring the wrong thing. If we're measuring how far down has the organ come through the pelvis, I don't think we're measuring the right thing. Whereas if we're looking at A, how much it's deviated to the left or the right, and B, what the level of tissue stiffness associated with that is. So when I'm objectively measuring my patients, I use a scale I've devised myself, which is a mild, mod, severe, which isn't been validated. But using that, yes, we're getting anatomical change. And the anatomical change is actually immediate. And women feel that themselves. That is just such a lovely part of it, is that you can find the talus and go, right, okay, so your talus here is really, really tight. Does that feel like it's in your bladder, even though your bladder is here? And then you release that and the bladder just shifts, and she feels it. She feels the space in the vagina opening up. She feels the bladder shifting, and she stands up and she's got no bulge, and it's straight away. And it is a beautiful thing to see.
Another compounding factor here is that the symptoms that we associate with prolapse that you've described, heaviness and pressure and urinary symptoms and bowel symptoms, these symptoms also occur in men.
Yeah.
Have you had any experience treating men with these problems?
No, I haven't. I don't treat men, so I can't really speak from that perspective. So I don't really know.
I think it's particularly important that we think about this because the myofascial structures that are laid down in the embryo are very, very similar for the male as well as for the female. And the myofascial structures that are the ones that you work with are present and all not identical, but certainly similar for men. And I think this raises the question, how much of the symptoms are truly related to the pelvic organ prolapse as the driver of the symptoms, and how much is the pelvic organ prolapse an innocent bystander that happens to be a demonstrable physical sign that we can use to characterize the patient?
Well, I think what I say to my patients, and all of my patients are female, and the majority of them are postnatal, either, you know, months or years down the line. But what I say to them is that, again, moving away from this concept that a prolapse is either on or off, it's either fallen or not, actually it's a spectrum. So if what we're looking for is this disruption in arrangement within the pelvis, that it's a spectrum. And what I'll say to them, because again, we know in the research, in the literature, that there is no inter-arter reliability. You can have 3 different professionals look at a woman over a month and she's got a prolapse, she hasn't got a prolapse, and it's the same woman within the same few weeks. And actually, what I say to my patients is it's a spectrum. You've got tension happening because of, for most of my patients, birth injury, but not always. And that changes the vaginal shape. And for some women, that vaginal shape is sub any symptom levels. It doesn't even matter. They don't even know about it. And then there's the vaginal shape that's a little bit more, that is maybe going to get picked up when they go for a smear test or something, and they get told that they've got a prolapse and they don't know about it, all the way up to a severe vaginal shape change, which I feel is just really concurrent with their symptomology. I can press their symptomology. I can put my hand in and go, is that your bladder pain? There in the talus? Is that your place where you feel like you can't get the poo out of? There, where the episiotomy scar is stuck to the rectum? And so I feel like through the touch, I get a lot of confirmation on that it's an anatomical disruption that is giving them the symptoms. But I don't really know about men, because I don't do that.
Well, I think we need to include some men as well and see how we get on. And I'm sure that many of the therapists who are involved in our conversation today may also have some experience treating men. So we'll look forward to hearing from them. One of the things that you described in your talk, which one always hears in the context of pelvic organ prolapse, is the complaint that a woman will often have that something is falling out. In my experience, nothing ever falls out of the pelvis. It's always pushed. It's like the detective novel where somebody falls under a railway train. You know, you don't fall under a train, you're pushed, typically. And with that comes a set of physical findings that are outside of the pelvis. The typical patient with pelvic organ prolapse will also have some degree of abdominal distension, for example. Would you like to talk to some of those factors?
Okay, so in my mind, those organs have been pulled into not quite the right place. So the abdominal distension, I think, comes from this, again, not everyone has scars, but I think it's a major player. So where there's a puborectalis dysfunction, and often the scars run really close to the anus, and where there is a gathering up and a knotting up of the tissue right here, really close to the anus, then there is a real difficulty in regular bowel motion. And then I think there's a lot of backlog then and bloating. So I think that's some of those symptoms. And I think that kind of abdominal down drag is because of this tension, this pull. So I think the pull is happening right down here. And that pull basically works all the way up the chain. For some women, you even see it in the shoulders and the ribs. So for the women that have had a severe pelvic floor injury and then they've lived with it for many years, there's even a decreased excursion of the rib and the lower shoulder in the side where there's loads of tension. There's also a change in foot position. There's a type of foot pain that it comes from the same thing of that tension within puborectalis, pubococcygeus, just locking up that part of the back of the pelvis. And I think the pull goes all the way through.
That's interesting. In my other thought was about constipation and how very little patients understand about bowels and bowel function. And really, from my years of practice, it seemed to me, I don't want to keep talking about trains, but there is a similarity here in as much as the normal bowel movement is a little bit like the train leaving the station. And when the bowels have moved, the rectum is empty. And there's the more common pattern that we see in patients with prolapse, where cars come off the train.
Incomplete emptying of stool. It's
And
massive.
in the same way, they don't empty the bladder well, they don't empty the bowel well. And these are
I think it's
patients,
primary
patients
symptom.
who typically are recognized by having to use a lot of toilet tissue because they have to wipe and wipe and wipe in order to get clean. And as they get better, they need much less in the way of wiping because they're much more effectively emptying.
Yeah. And also that wiping is literally a disruption that's happening close to the anus. And this is exactly why I have this mug, because women will say, oh, I'll ask them, and how is pooing? How is defecation? Oh, well, I get constipated. And I want to say to them, okay, so is your constipation like this, like a type 1 rabbit dropping? It's really dried up, tiny little pieces. Or is it actually more like a type 4? It's soft and smooth, but it doesn't all come out. And that tend to say, if the constipation is that dried up rabbit dropping kind of little stools, actually we need to look at fluids and diet. Whereas if they've got a nice type 3, type 4 soft stool, but it doesn't all come out, then I'm looking for the mechanical reason within their pelvis as to where they're getting stuck. And then when I go in to do the manual assessment, I can just feel that. I can just say, right, so there's your episiotomy scar. There is where the rectum is stuck to it. Is that where you have that uncomfortable bulge when you're ready to have a poo? So it's kind of unraveling the constipation that is genuine, bowel focused, it's dried up, the digestive system or the fluid system isn't doing well, or is the poo getting all the way down into the pelvis, but then it's not getting out? Because that, I feel, is my job. And I'll say to them, look, if it's a type 1, you're going to see a nutritional therapist. If it's type 4, but it's getting stuck at the exit, then that's my job.
Can you think of any ways in which manual therapists and movement professionals might better integrate these principles in their own work?
Yes, so it's just about a focus shift. So obviously people that are trained in MFR and scar release that also have insurance to work internally, can just get in there and release those scars. And actually, it's so much of it is right at the perineum. This thing about actually the vulnerability to that tension seems to be right at the entrance. So actually, for those who are trained to do scar release and are insured to work internally, actually the perineum is so important. More that I think it's tempting to kind of go straight in and go, well, it's tight through here. But actually, I found that you can get so much more profound change quicker by working at the outside. But obviously, internal scar release is not available everywhere, but basically anything that acts to release and open through the pelvis. So that can include releasing through the upper body and the rib. It can be releasing and helping the foot. So because all of that just helps with the pelvic alignment. So basically any release focused movement, anything that's focused on releasing through the back, the hips and the pelvis, anything that's focused on manual therapy to release around the outside of the pelvis, or anything that feeds into the pelvis, it's all really helpful. It's a shift away from that old way of saying, well, if you've got a problem in your vagina, you need to do your pelvic floor muscle exercises, squeeze, 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 even if it makes it worse. And I think the other thing that we can all do is just watch this language about falling out. You know, that's just, we got to stop telling women as a society that their bladders, uteruses and rectums can fall out, because as you say, Neil, they don't.
But as a sort of to begin to close this and let Steve have a chance to talk about his experience with pelvic and back pain, I think we should also talk a little about pain. Pain is a very common symptom in this group of patients. Can you say a little bit about how the presence of pain shapes the way in which you approach the patient?
So for me, that confirms that it's a biotensegrity, you know, it confirms this approach. The presence of prolapse pain is not explainable with the concept that bladders have fallen, but it is explainable with the concept that it's tight is pulling. So actually that prolapse related pain actually just really guides me into where. So I'll take a long subjective and find out, so where exactly is that pain? Where exactly is that discomfort? You know, actually a lot of the time it's around the scars. And then I do a lot of sort of global movement assessment. I look at walking, single leg stand, squat, and it kind of hones it. So is that your pain? Is that your pain? Is that your pain? So by the time I'm actually getting in there and I say to her, I'm looking for the tension that is causing your prolapse. So I'm looking for your prolapse pain. So is it scratchy and sharp there? Is it that tender, bruisey ache? And actually that just kind of deeper informs what's happening with these patterns, is the type of pain as well as the location.
And how successful have you been in dealing with these pain problems?
That's the first thing to go, actually, is, you know, if I'm honing in on, say, you know, a scar running through the puborectalis and she's got problems with defecation and urination, and she's got this part of her perineum and her vulva which aches when she walks, that actually, by coming in and just gently myofascially releasing that point and just taking the edge off and allowing that tissue to unfurl and uncurl, often the pain is the first thing to subside. And then by working deeper into the tissue, then you can correct the organ arrangement. But yeah, the pain and being able to drop that prolapse related pain is good. It just reinforces their like confidence and belief in it. And especially if I can say, I'm going to find pain there, it's going to be roughly this area of the pelvis. And if I can say that before I get in there, it just all helps with this whole trust thing, because, you know, she has to make herself so vulnerable. So for me to predict where I'm going to find that pain, and then, you know, in typical myofascial form, I'll talk to her as I'm myofascially releasing into it, right, you're going to feel a crescendo now of that tenderness, and I can predict it, and I can say, is that spiking now? Yep, that's spiking now. Okay, and is it starting to come off? And as it comes off, a layer of that uncurling and unfurling goes. And then again, then I'll say, right, now I'm going to work a little deeper into the same area. And then again, it'll crescendo up in that typical myofascial form to then come back down again while the tissue unfolds. So it really fits with the way that we can release the fascia in the rest of the body.
Thank you very much. I'm going to take a few minutes to work through some of the questions in the chat. And while we're doing that, I'd like to invite Steve to say a few words about his experience with back pain and pelvic pain.
I'm just going to step in with a technical note, if I may, which is that we've discovered that the program is streaming to Chris Clancy's YouTube channel rather than to the archive YouTube channel. So if anybody who's in the Zoom meeting gets a message from someone on the outside that they can't find it, that will be why. Just have them look on Chris Clancy's YouTube channel, and then later we'll move it. Thank you.
Well, first of all, I'm much more interested in hearing what Anna has to say than what I have to say, because I'm strictly a mechanic, and what happened to me is that I would be getting, I started specializing in non-surgical back pain, and I would get more and more women with low back and pelvic pain, and ended up having it as a major part of my practice. But I was not interested in the gynecologic and urologic aspects or visceral aspects. Mine was strictly mechanical, and it's a completely different approach. And I'll just go through some of the mechanics of what I do, but I know it feeds directly into what Anna's been discussing, because although I didn't treat those conditions, often these patients were referred to me by gynecologists who were treating the other aspects of the pelvic pain and seemed to recognize it was a mechanical aspect to it. So let me see if I can just show you some of the stuff on my screen. I just like that one. That's, for those of you, this is, of course, a lot of you don't remember Elvis Presley and the pelvis stuff, but it was a big pelvis thing. All right. Well, the classic model for the pelvis has always been the pelvic arch, and it's been the keystone arch, where the arch is pushed together, leaning up the center keystone, which pushes the arch apart. And Levin, who is still very, very active in the fascial program and low back pain, back in the 90s, late 90s, I think they came up with this concept of form fit. This is, so it blocks it with this. And this is force fit, where the two sides are pushing up, the walls are pushing up against the center keystone. And this is a combination of form and force fit, where the sacrum locks into this in both this form and force. And of course, none of this makes any sense. You get the pushing down the whole system. So you get, you need a lot of friction in that kind of system to work. And he says, well, there are ridges in this joint, but it's synovial joint, and it's slippery as every other synovial joint. It's got cobblestones in it, but other than that, it's still very slick and will slidey. And besides that, even more so, I'm going to move through this very quickly for you because it's not important. But actually, when you get to an arch, you want to be pushing down directly through if you were loading this way, pushing straight down, forces normal instead of pushing out as it would be in a keystone arch. So nothing makes sense. Anatomically, and this is in Grant's method of anatomy that goes way back, the sacrum is actually falling out of the pelvis. And if you look around at all the pelvises in structures, and particularly if you go to the Natural History Museum and look at all the animals, you'll find that the sacrum is actually falling out of the pelvis, and you hang there between the rings of the ilium. And these illustrations are my friend Richard Dontigny, who does the most beautiful things I've ever seen in drawing pelvises. It's his special thing. But the pelvis actually, the sacrum actually falls out of it. So it's, the sacrum is not wedged in, but theoretically would be falling out. But of course it isn't, because it's part of the tensegrity system. And as part of the tensegrity system, it's going to be tension into the whole system. And as I said, you go around, it's in all structures. If you look at it, the sacrum is falling out, and Levin is absolutely wrong on this. And I've discussed this with him on many occasions. And of course, he's made his living on this, so why bother? But if you look at it, you see that it's really suspended in this tension network of structures, so that the pelvis is not a supporting ring, but a tension bicycle wheel essentially. And of course you can't do it if it's just hanging from the hips. You need two hips to hang it from. And of course you can do it on one hip. So it has nothing to do with hanging. It has to do with the way it's suspended in a tension network as we have here. So this, what has been referred to as the pelvic floor and is really the pelvic outlet, I would think, is really this wall of fascia and muscles that go and link into the sacroiliac joints. So you're talking about a pelvic wheel rather than anything else. And so all those internal structures that are falling out are really suspended as hubs in a tension spoke wheel. And so you have to pull it from the inside and pull it up rather than trying to push it from the bottom up. So it's works nicely that way. And again, this is just how wheels work, that it's not a wagon wheel where things are pushing down, it's a tension wheel where the perineum are tension and pulling these things into the system. And again, it's biphasic, so you bounce back and forth from one to the other, and you need all these things. And this is another one of Richard Dantigny's drawings where he shows all these ligaments pulling as a functional tension structure. Now, in my experience, I found that there were certain specifics for mechanics that we would call the sacroiliac joint and piriformis syndrome kind of thing, because from the examination point, you would get these structures that would do it. So the piriformis muscle is out here, but crosses in front and crosses in front of the sacroiliac joint. And then you have all these nice structures hooking the hip and the pelvis together. I would find that these people would have more restriction in backward bending than forward bending. Now they would have discomfort forward bending, but they really had a sharp pain in backward bending. And so they would, neurologically, they might have some symptoms of pain going down the leg, but they never had any objective symptoms and never had reflex changes and things like that that you get with nerve root compression. And I don't know why. And they would have some tender points that were very specific. They would tenderness at the pubis. They would be tender at the sacroiliac joint dimples, and you can do that. Let's see if I have, and at the sacrospinous ligament, which is inside, and at the coccyx. And these would be specific tender points that I would find. But they would have no tenderness of the sciatic nerve, which is typical of a herniated disc. From inside the pelvis, and this is from inside looking out, they would have tenderness at the coccyx and the coccygeus and sacrospinous ligaments, and they would have an exquisitely tender point right at that ischial spine. I mean, and they would often say, there it is, that's my point of pain. And from there, I would usually, so it would be this sacrospinous ligament structure, and it's a so this is doing the examination of restriction of motion. Actually, the joint that is restricted is the one that moves, because as you bend forward, the ilium rides up with the spine instead of staying back down. And it's a loss of joint play, which I'm not going to get into deeply in at this point, but as far as I'm concerned, the majors are manipulable lesion, let's call it. So I would then mobilize these tissues by just trying to restore the play movement here. And these are just playing the game and the various ways of doing it. So I would actually go inside the pelvis and release those ligaments again it was tight and I was releasing them, allowing the pelvis to then reestablish its balanced structure. And I've never restricted any type of exercise in the back because I can't tell the difference between one exercise and the other. All exercise is the same to me. So lifting a box is no different than lifting weights, and I never restrict anyone with backache if I'm doing any lifting or exercises at all. And that's about all I'm going to say. All right.
Thank you very much.
Quick view.
Anna, there's a lot of interest in your training and background. Could you say a little bit about the road that you followed to lead you to today?
Well,
Yeah.
I started out
Alert
as,
from
oops, I don't know where that,
AOL password required.
oops, sorry about that.
Alert from
Well, I started out as a cutting orthopedic surgeon, and I learned all about. I actually did. I spent 3 months of my surgical training in the gynecologic service, so I learned all about pelvic prolapse and all that sort of thing. But when I started taking care of back pain, I found that I could do better by soft tissue work than I could ever do by doing the surgical work. Just by circumstance, during my orthopedic training, I spent an academic year at the University of Pennsylvania and fell upon John Manel, who most of you have never heard of, but one of the pioneers in manual medicine as an MD. And it was just, I just happened to be there the same time he was, because he was only there for a short period and I happened to coincide. And he ran a little clinic for this firemen and policemen in Philadelphia. And he hated the job. So when since I got interested, he started me doing all the work. And of course, there's no better way to learn than by just being thrown to the wolves. So that's what happened. So I learned manual medicine from him and then took it into my orthopedic practice. And then while I was treating back pain surgically, I realized that I could do better non-surgically. And so I moved in that direction. And again, this pelvic stuff started also when I was up in, I spent teaching, I was teaching at University, at Michigan State University College of Osteopathic Medicine. And one of the professors there, Paul Kimberly, who was head of anatomy at Kirksville College, talked to us about the pelvic floor and how to treat that. So I picked that up from him. So it was just bouncing back and forth from these different people. So I had the combination of Manel's work coming from one part and the orthopedics from the other, and then the osteopathic moving into it. So I got it from three different directions and came up with sort of what I do.
That sounds fascinating. And what about your chemistry, Anna? What sort of mix of things brought you to today?
Okay, so I trained originally as a physio many years ago, and then I trained in myofascial release with the Gyn College, which are one of the biggest trainers in the UK. So I did their full myofascial certificate and just absolutely fell in love with myofascial touch. And that was when I first heard about Biotensegrity. And then I was just starting, I had my own babies, had my own kids, had my own birth injury. And as many women's health physios, I think most women's health physios were MSK physios, have their own experience of birth injury and then go, oh, I better do something about this. So I started down the road of women's health physio and then had my own sister seal. So I started with what I'd been told, which was Kegels, and I found it hugely ineffective. And the part of me that had learned all of this myofascial stuff was just like, well, how are the Kegels going to work? So, I'm a Biotensegrity structure. So, I just had all this going around in my head. And basically, I just started self-exploring and self-treating. And I found all this tension. I found that the tension that was causing my cystocele was the tension that had been causing that hip pain ever since I'd had my first child. And this story just unfolded in my own pelvis. My cystocele went away, the penny dropped, and I realized that the whole way that this condition was being understood wasn't that, it was this. So I started tentatively offering it to my clients because I was a women's health physiotherapist, and I would explain to them, where that had come from and that it was experimental, and it just kept on working every single time. And then after some years, I felt like I needed to write a research paper to show that.
Interesting. Diane Woodruff asks if there are any type of movement program that you offer either during or after your treatments.
So actually, I have a wonderful colleague called Claire Sparrow. That's Claire, C-L-A-I-R-E. I'll write a link in the chat box. And she's this wonderful Pilates pelvic expert. And she is so into Biotensegrity. And we used to work in the same clinic, and she would watch my patients walk in and then watch them come out. And we're just so on board. So basically, she has designed a movement program that is perfect. I'll put the link of it in the box, and she uses breath and awareness and movement to release the pelvis and to build in awareness of that sensation of release. So, and I'm really lucky that over lockdown, she's put it on as an online program. So I can now send all of my manual therapy patients to her course.
Very good.
Pleasing.
Very good.
It's very pleasing. I'll put the link in the chat box. It's very, very pleasing.
I see a number of questions about Mula Buddha, about which I know nothing, but I'm anxious to hear. So I think we should open the microphone and ask that questioner to ask their own question.
Hi, Neil. One of the people that was talking about that was me, and Mula Bandha is a yoga practice that is taught, well, especially through the Ashtanga lineage, that, in my opinion, is actually a very subtle practice, just bringing awareness, being aware of that pelvic diaphragm. There's a doming up that happens. But it was taught, it probably still is, I'm no longer teaching yoga, or especially been decades even in the Ashtanga community, but it was originally taught much like a Kegel.
Yeah.
And so I never did the practice that way, but my women friends who did had a very, very hard time birthing their children, because it's just counter to what the body wants to do.
Actually, our vaginas are supposed to be really flexible and dynamic. Is it the Mula Bandha that so I'm not a yogi, is the Mula Bandha the hyperpressive system, I believe, has some roots in that? Is that correct?
I'm not familiar with that languaging. Maybe someone else could hop on board if they are. When I originally started practicing Ashtanga yoga, it was like if you had to go to the bathroom and wanted to stop midstream. So people were contracting and holding, not just in their practice, but throughout their lives. And you lose this ability to be organic. I mean, it's like shifting you to one side of the scale, whereas, I mean, listening to your presentation, Anna, that's my experience in my body. And ultimately, in my opinion, Mula Bandha is an energetic seal. And the more subtle the more we were able to access this on a subtle level, the more powerful it is. Similar but different to what Leonid and John Sharkey and Joanne and everybody's talking about, this light touch. But it's even lighter than needing hands, because when you put your awareness somewhere, it starts out as being a very subtle touch, but with awareness, it's huge. And I believe that people can do, we can shift what's happening in the tissues, and perhaps this is something you're exploring in terms of your own practice and how people carry through with this when they go home.
Well, yeah, this is it. So I'm not really a yogi, so I don't really know about the Mula Bandha to speak of. I've heard of it. But there is a whole thing about the unwinding of that gripping pattern. So some women come see me and they were perfectly healthy until they had this birth injury. And now what we're dealing with is largely a scar. And then we can release that scar and then their positive movement patterns will flow back and they'll be okay. But for some people, it's something that's been around for a long time. And, and actually so much of it is this postural or emotional gripping. And then there's layers of that where people are afraid of their injury getting worse, of something falling out, of actually just letting themselves go. Actually a lot of women, again, I speak from this sort of feminist perspective, are holding in, and that is just so unhelpful for the pelvic floor. We need to let it go, just absolutely let it go. And for some people, it's the work needed is not pelvic floor manual therapy. For some people, it's a completely different thing that they need in order to learn to let go of their pelvic floor, in which case I would refer them on to, birth trauma counselors, emotional counselors, movement therapists. Different people need different things to aid that deep release.
And it's such an interesting discussion. And another thing I'm just going to pop in here, hearing Neil inquire about working with men's health, and perhaps in this community, there are people already doing that. And there's the opportunity to collaborate or for you to train them and then for them to take that into their own explorations. And it will be very exciting to see where that goes.
It's the only limitation that I have for that is capacity. There is just, I have so many women on my books, so many women. Capacity, this is so I have no, it's not that I don't think these things are happening for men. They are,
and my suggestion is to you, serve those women. Women need this work. And eventually, if you're not already doing it, I'm sure we'll find you training other practitioners. But maybe we have in our community already physiotherapists or other therapists who are already working this way. And one of the things that we're doing with the Biotensegrity party, with the Biotensegrity archive, is creating community. And I just encourage you and invite you to have a conversation, because you need to do the work you're doing. And there's probably someone else out there who already knows about Biotensegrity, who would just love to learn from you and to then take that and really explore in their own practice. And it's such important work.
I think I'm just going to jump in and say we're after the hour now, and we kind of go into the more community mode at this point. So if people want to, they can turn their cameras on. Sorry, but go ahead, Anna.
I can't remember what I was going to say. I think my message really that I want to say is just that all Biotensegrity principles apply to the pelvis, which we all know. So I think that's the thing that crosses this. Is it a female pelvis or a male pelvis? All pelvises are Biotensegrity, and all of the Biotensegrity rules apply. I think the thing that keeps getting my goat, the thing that drives me often, is the amount of it is women that I see that have been told, well, you've got vaginal pain, so do loads of squeezing. And it's like, it's completely not going to work. And it's the same for men, isn't it? Who've got pelvic pain. If you're told to do lots of squeezing, that's not going to work. So,
Neil, where are we in our questions? There are a lot. And Steve had a comment too, I think.
We are. I'm reminded listening to Steve about the experience that I've had with patients who have had pelvic fractures. It's very common to find orthopedic surgeons fixing the pelvis as if it is a bony basin without joints. And I I see patients every year who have had a metal plate placed across the pubic symphysis, for example, and invariably these plates break. And they break because the pelvis itself is a dynamic structure and we don't seem to do it justice.
Interesting. And I think, Steve, you had a comment too, because I think I'd sort of like to hear from Carol, because she also had a question, but a lot of this work relates to the work of John Barnes. And I know, Steve, you and John go way back. And I know that my understanding is most of the Barnes trained people are trained in Biotensegrity. But can you talk about that, Steve, too?
Yeah, I met John Barnes actually I think it was in the 60s. I mean, that's how far back we went. And I was introduced to him by John Manel. So John Manel and John Barnes had an interface, and I did with both of them. I taught at a couple of John's impromptu courses. I happened to be around. I walked in once, and he said, "Oh, why don't you give a talk?" So I gave a talk at his course once, and a lot of the techniques and concepts blend together. John Barnes does this myofascial release, which is one of the techniques, and he does a lot of pelvic mobilization types of things and incorporates much of what I talked about. I had the advantage of being also, as an orthopedic surgeon, I could stick needles in things, so I often would supplement it with local injections into the sacroiliac joint and into sometimes the piriformis insertion. But that was icing on the cake. I probably could have done without it. It was just made my life a little easier and faster. So my routines on these people that I saw was usually 4 treatments. I mean, I see them and treat them and then maybe see them once or twice again. And then the 4th treatment was just to see how they were doing. I mean, that's how quickly this works. When you, yeah, once you learn that it's, you know, all you have to do is let that give that pelvis an opportunity to balance itself by releasing those tighter structures, then life is easy.
It's the same with this method. It can happen so quickly. And as I was saying earlier, the more I've done it, the more I realize I can be fast by working on the more superficial parts of the funnel. If it's the funnel and the bowl, it's like the whole bowl is like this. And the more I can work on these bits here, the more that shape will just shift and change, you know, quick, which is good because, you know.
Yeah, I left out one part that I always treat as the thoracolumbar junction. Somehow or other, that thoracolumbar junction seems to be a key to the integration of the upper body and the lower body. And I found that even when I would find most of the problems in the pelvis, I would always treat the thoracolumbar junction as well.
One of the things that Anna touched on, but we never really explored, was the involvement of symptoms in the feet, particularly pain in the feet associated with pain in the pelvis. And that's something that we will be exploring a little bit later this week in the fascia hub. But the innervation of the small muscles of the feet is exactly the same as the innervation of the pelvis. And for any of you who have had a pregnancy, you'll know that in the last days of a pregnancy, your feet ache. And feet ache because the pelvic floor is being stretched. And as those nerves are stretched, the adjacent nerves in the spinal cord say, oh, for goodness sake, tell them what's going on down here. And the body appreciates that as a sense of pain in the feet. So there's a very close relationship between feet problems and pelvic floor problems. And the other side of that is that oftentimes when you have a patient coming to you with problems in the feet, we should remember to include the pelvis as part of the territory of interest. Anna, would you agree with that?
Absolutely, yeah. Yeah, feet and pelvises are just hugely linked. There are parts of the back of the pelvis where you can replicate the foot symptoms, which I've always considered to be neural, and there's a whole foot position shift that will happen with those really chronic pelvic patients. So actually, I always really encourage the barefoot walking. I'm a big fan of barefoot walking. I really see and feel in myself as well how that aids a nice, flexible, dynamic, responsive pelvis.
So Susan, I think we can take questions from all corners now.
You can, Carol, because you worked with John Barnes, and so much of this has to do with his work. I didn't know if you had any thoughts, but then I'm gonna let you orchestrate, Neil. But I just, sorry, selfishly wanted to hear from Carol on that.
Yes, John talks about John Manel and Steve Levin too, quite often. But John Barnes does teach this approach. But Anna, I was interested. I have learned what you're talking about, and I've learned the palpation techniques. And then I have received pelvic floor problems for hip problems. Basically, I had a tear of my lateral tendon, my gluteus medius tendon and hamstring, and we couldn't get at the pain. And of course, as soon as she went internally to the obturator internist, it was right there. And but she wasn't holding long enough, and it drove me nuts because I could feel it start to unwind, and then she'd stop. And I was wondering, what is your how do you judge how long to maintain pressure?
Okay, so on the hip front, there's this pattern that there's a symptom that women will say, and I presume men as well, of a hip pain deep. They say it's in here and I can't quite touch it, and it's like, yeah, that's because it's in your pelvic floor. So my sessions are an hour long, and now since April, I'll do all of my first sessions online and make sure that we've told the whole story, and I've explained about biotensegrity and set them going with a little bit of self-exploration, self-mapping, a little bit of confidence building in what's going on down there, help them like join the dots of what I'm saying and what they're feeling. And then they come in and it's an hour-long session. It's 10 minutes or so of, have there been any changes? How are you doing now? And then essentially it's 50 minutes or 45 minutes of vaginal manual therapy. So
but how long do you maintain pressure?
Well, quite a while. So I don't know if I would know in minutes. So
yeah, but you're not in and out and in and out. You're not just poking. That's that's the point I'm trying to make.
So basically, what I do as well. So I'll explain everything that's happening. I'll give them loads and loads of information about exactly what I'm going to do, exactly what they might feel. Check again, check again, check again, check again. Are you still on board? Do you still understand? Are you still with me? Are you still okay? And then in standing, I would kind of make my assessments, okay? And then what I tend to do is actually sit down and rest my elbow, and then I work like this. Super light.
That's what Barnes teaches too. Yeah.
So I sit here quite close to their feet, and I've got my elbow on, and then I can be super controlled, super gentle, and I'm working like this.
So are they standing?
Say again?
They're supine, right?
They're supine. They're supine, knee bent, okay? And I'm kind of coming at them from this angle. And as I follow the releases, I may do a position change and kind of follow the releases. So I'll be kind of here, and then following the releases, moving my hand. But yeah, I'm going to like follow each point for like.
Exactly. That's what the tissue does. You curl around with the tissue.
Yeah. And it's, and because this tissue, this uncurling, unfurling, I keep saying it, but oh man, it's just such a thing to feel.
It's spiral.
And then come onto the scar, wait for the scar, and it starts to shift, and I just follow and follow and follow, and then I get to a point where it stops, and then I'll usually say, okay, you felt all that, release. Okay, now I'm going to bring my fingers back to where they were at the beginning, and I'm going to do all of that again. because I just really feel like absolutely every single movement with my hand has to be explained. They need to know exactly what I'm doing. Are you still on board? Does this still make sense to you?
So important, so important. That so many of them have been traumatized, and maybe not meaningfully traumatized, by husbands who didn't know or partners who didn't understand. And
trauma, there's so much birth trauma, there's so much obstetric trauma. These women are coming with these injuries, and as we know, the fascia and the scars hold these memories, and they're right here, the most vulnerable parts of them, showing me their trauma.
Right. That's outstanding. Beautiful.
It's
That's
just got to be maximum trust, maximum calm, maximum reassurance. You know, are you still with me? Do you still understand? Do you still know what I'm doing? Does it still make sense to you? I've lost your sound, Carol. You're muted, Carol.
Carol?
Yeah, I muted myself because I wanted to hear you speak. I found myself interrupting you because I was so excited, because what you're describing to me is, to me, that interface between the therapist and the patient, that you have to, especially in terms of the interoceptors, and you have to build the trust so that they can relax enough to allow the tissue to respond to your energetic compassion and your touch. And it's such a gentle touch. It's not poking. It's a gentle. And very often I'll do a clock to ask them where the tenderness is before we start, and then we'll go from one position to the next. But they are in charge, always in charge, and that because of the trauma, because of the vulnerability, it's so important. That you do what you educate the way you do. This is brilliant, just brilliant, and this is what John Barnes teaches too. So it's a nice validation of that connection between therapist and patient, and doing what the tissue is calling for, and you can feel it right through your touch. Yeah.
I learned from the Jing College, and they take a fusion approach, which
includes very close to Barnes. Jing and Barnes are very close. I think they call it myofascial induction, and I did a review of the literature of what how the manual therapy approaches are different from the 4th edition of my textbook, and the Jing method was the most similar to the Barnes method of this energetic connection.
Yeah.
Thank you. Brilliant.
Thank you for having me. I need to put in the chat box this course of Claire Sparrow's. All right, hang on, because it's just beautiful movement that's all about awareness in the pelvis. So clairesparrowpilates.co.uk. Right, let me just.
And John Sharkey, a couple of people have asked for you to kind of weigh in on this, and I don't know how much of this relates to, Neil says some of it relates to what's coming up, but I think people can get ready to unmute themselves and ask their own questions. Wilbur, I know you've got some.
Let me just put this Pilates in here, otherwise I won't. Hang on, let me do that. It's www.
Putting it in the chat, Anna.
Yeah.
And Anna, perhaps after John has finished speaking, you could share with everybody the course that you are offering.
Well, really, it's just a really short lecture. Really, I've covered a lot of it in what we've said. So this is my friend's course, clairesparrowpilates.co.uk, and it's called the Whole Body Pelvic Health Course. And it's basically a movement program, but she designed it really a lot with my patients that I was doing release work for, you know, and now it's online, so it's great. What was the other question that you asked me? Oh, about my little course. So really, I've got my first paper out, and then my second paper's on the way, and I just needed to just explain the science of what it is that I'm doing. What is Biotensegrity for women's health physios? So it's like an hour of video lectures. A lot of it is what I've just said there, but I'm offering it free for all NHS women's health physios, because, you know, I know that they're under a lot of strain, and so that's the thing.
And you've got a coupon in the chat for that too, right?
Yeah. There's a coupon in the chat. So you can just go to my website, and then if you go on the For Professionals page, it's on there.
All right, over to you, Mr. Sharkey.
Oh, really? Well, first of all, I want to say, Anna, well done. That was a fantastic presentation. I think anybody involved in Biotensegrity would be very pleased with that particular set of analogies and descriptions. And you used your own body. You got up and you moved, and that's because there isn't another model. That's fantastic. I really got a huge amount of joy from that. One of the things I didn't hear tonight was the word inhibition. And inhibition is a huge aspect of this conversation. And to be honest with you, we can have issues which are descending, or we can have issues that are ascending. Where does the pelvic fascia begin? Where does it start? You know, does it start at the feet? Does it start elsewhere? There is embryologically a relationship between the pelvic fascia and the feet. But however, if I can just come back to the word inhibition as an example, and let's just say, for instance, I talk about, I hope you can see this, am I holding it correctly? The rectal angle. And this rectal angle is created by the puborectalis muscle, which is basically contracting, and what it has to receive, it has to receive inhibition in order to be able to defecate. So part of the issue is that the problems could be coming superior to inferior, or they could be coming inferior to superior. In other words, they could be ascending or descending. Another quick little comment, and thanks, by the way, for people wanting to hear anything from me. And I loved this, Anna. What did you say? Unwinding, unfolding. When you talked about
the uncurling and unfurling, the puborectalis, it becomes like this, and then it's like a band when it's really tight, and you come onto it, and it literally under my fingers, it's like whoosh, and it's a wider piece of muscle. And then again, you release in deeper, and it's like pages of the book. It's like, I say this to my patients as well, it's like pages of a book get stuck together through this puborectalis, and you can come right onto where the pages are, and it just, and amazingly, what they say is, I can feel there's so much more space. It suddenly opens their whole vaginal space, which is the opposite of this prolapse sensation of there being a lack of space. So the puborectalis does this, and then there's more space. And this is as well where people get told I have a short perineum, and actually, and I say to them, well, where's this perineum gone? Did it go in the clinical waste bin? No, it didn't. It's stuck up here. So you can come here, and then it uncurls and unfurls, and you get your perineum back.
Absolutely. So uncurling and unfurling, that's lovely, because I just, because you said that, I organized a little piece of paper in the event that somebody might ask a question. So what we have basically is, I suppose you could call it a kind of an accordion type of effect. In other words, that this idea that stretching a tissue is going to rectify the problem. Stretching is one of the worst things you could possibly do to living connective tissue. Now, most people that are stretching are not in fact stretching at all. What they're doing is in fact lovely. But the facts of the matter are, connective tissue, collagens, you know, they're all made up in this regard. But you have this kind of accordion effect, or if I think I've shown this before, little back scratcher that my daughter gave to me. And you see that, oh, well done. You see, there we go. Anna, we're on the same page. Well done to you. I applaud you. That was brilliant. And you can see the things then lengthen without any one particular aspect of the structure lengthening. But of course, it can become stuck in what some people would call a shortened position or whatever. So there's so much I could say, but I think you just did a brilliant job. I don't want to, you know, impeach
and then this folding funnel thing, and then like here it is, and then here is your dragging down. Here is your dragging down.
Well done, Mike. I'm so impressed. That's fantastic. You really have been paying attention. You've been listening, and I'm really pleased. Really pleased.
Well, thanks for having me.
No, well done, you. That's
Anna, I had John spotlighted, and then he said, well done. And I and everybody on YouTube totally missed what you were showing. Could you show again?
This funnel.
Okay.
So, you know, as this sort of puberectalis and this concertina effect there that John was just talking about, and then you get a dragging down. Yeah. So as that crunches, you know, fold, dragging down, release, and happier arrangement.
Great. Thank you.
well done. Really great.
Who else? Wilbur, you had questions, didn't you?
Did you see this one? Somebody said, did they miss the other thing? Did you see this one? I think there's another one.
I missed that one. Let me spotlight you. Hang on.
Yeah, those are great.
Did you see this one? So this, what do they call it now? A wire mandala or something. And it's this concertina. So there's, you know, this concertina ring. And then as you release it, you know, essentially, you know, that whole rim of vaginal tissue just becomes, you know, more flexible and looser. So this is the other little toy thing that I was showing.
Great. I love models, so I appreciate seeing that. Thank you for repeating it for me, and also for anybody who's watching this after the fact.
Great, great. Who's watching the questions? And Wilbur, are you there? It looked like you had questions. Maybe he stepped away.
I'm watching them, Susan, and I'd also sent them to Neil. I don't know if Neil is still there and keeping track or not right now.
I'm here and I'm keeping track to the best of my ability.
Yes, absolutely. Yeah, Wilbur did have quite a few questions.
But maybe he stepped away.
Yeah.
So anybody else, I think?
Yeah, Patricia had a question early on. Patricia Hopper, did you want to come on, Patricia, and ask your question?
Thank you. I can't. Oh, can you hear me now?
I can hear you.
Okay. I was getting a message that I wasn't being allowed to unmute. So I, looking at the anatomical drawings that Dr. Levin showed, I had a question about, I really also was really interested in this idea of uncurling and unfurling. And I was wondering if there's any anatomical depiction that captures that, or if it's something that only occurs in the function and wouldn't appear in the anatomical drawings. So just looking at those netter drawings, they just look like a tight net, right? Like a tight hammock.
I am find a drawing of that uncurling and unfurling process, which is why I've kind of ended up just using my body to show this, because I'm yet to find something that really shows that. So there's a term called rugae, which you can find in the anatomical textbooks, which refers to the folds within the vaginal tissue. And the area where the greatest folding is like right inside the sit bones. So on the perineal side of the sit bones. I haven't found something that accurately shows what I feel, which is that I can come on and then there is more of the muscle and there is more. And I actually have started using a completely different set of terminology in my own notes, because I was like, right, so I'm on puberectalis, and then puberectalis is released and I followed that. So now I'm like in there. Is that still puberectalis? Well, I don't know. So I've now in my own notes, I call things the perineal space, the posterior space, and the lateral space, because I feel like what we're dealing with here is a whole vaginal shape. And then as I release it, that vaginal shape shifts and changes. And there is space now where there wasn't space before. So what structure am I now on? And I don't know if I know. So in my own notes now, I'll say opening of perineal space, opening of posterior space, opening of lateral space. And actually that's something I like over the next year, that's kind of the next job of work really, is to try to document this whole shape uncurling, unfolding, the lengthening of the muscles under the fit, like that. Is it that I need to do that? That's next.
Lovely, thank you. I think this kind of shape shifting that we acknowledge in Biotensegrity, I'm just looking forward to it being more visible to everyone and how they think about how their bodies work, so that it's not so static. Thank you.
I see a question there about the embryology.
Yes.
And in particular, I think we need to remember that the human embryology is very different from our typical animal models, because we are tailless creatures. And the human embryo does actually have a tail. At about 5 weeks of age, the human embryo has a very impressive tail. And in the course of the next 3 weeks, between 5 weeks and 8 weeks, this structure dies back a little bit like a tadpole's tail. And so in making the human embryo, nature almost is like your granny making cookies, that it rolls out more tissue than is needed and then trims it. And that trimming is done by chemical signaling when you're only 6 millimeters long. And it's one of the situations in the embryo where there is great opportunity for variation. So within our patient populations, we're going to find very, very great differences, not only between the left side and the right side, but also between their structures and their sisters or their friends who lack the symptoms that they do. And I think we need to remember that we start with this very variable landscape of personal possibility on which lands the vaginal delivery or whatever, or the operation, whatever the other insult happens to be.
So I think we're mostly caught up with questions, unless there's a follow-up to that, other than the set of questions that Wilbur had.
Great. Can I'm just going to ask one thing. Oh, sorry, Carol, go ahead.
I just wanted to point out what a lot of people in the chat have pointed out, and Anna probably hasn't had a chance to look at the chat fully, but how effective it was for you to use your body as the kinesthetic model for how your whole body is affected by the tension of the restriction in the lateral and the difference between a rectocele and a cystocele. And I also want to point out that those of us who are doing myofascial release, but who are not certified to do internal work, we can get a whole lot done on the outside. Just through abduction of the hip flexion and abduction and releasing the adductors coming right down into the insertion. Well, it doesn't really insert, but the continuation of the adductor magnus into the perineal area and opening that up just with pressure and elongation and holding that, we can get so much done. And then up underneath the sit bones too, as you described.
The hamstring muscles attached to directly to some of these ligaments in the pelvic floor, and you work on the hamstrings and you're pulling on some of those and mobilizing those pelvic ligaments.
I think you can reach some of those deep posterior pelvic floor scars and tensions by working on the buttocks, on the glutes and on the external rotators. The external rotators and the back of the pelvic floor, are like right there. So you can come in that way. And also anything abdominally, you know, so that lower abdominal work, that deep glutes work up through the adductors, any release work here. And of course, the diaphragm in the foot to balance the whole system.
And cesarean scar, how many people I have been, I mean, they're weeping with gratitude when you release their cesarean scars because they have the paresthesias and the strange things happening in their pelvic floor. It's just simple scar release.
Yeah.
Well, we've got a few more minutes. I have a question. So John Sharkey talked about this idea of inhibition. And my question is for Carol Boggs and maybe Ed, if he's still here too, because Alexander technique, my understanding is uses this concept quite a bit. And can you relate it, or how would you relate it to what John was talking about, or would you not relate it? Carol, for some reason, I can't hear you. You're unmuted.
Carol, you want to take it?
But we can't hear Carol.
And Wilbur's back as well, Susan. Carol, do you want to jump off into a meeting room and we'll see if we can sort that out?
Or Ed can take it, or Diane.
Or Ed can take it,
yeah. The idea, the idea of, you know, excitatory and inhibitory neurons, and that we are making hopefully a generous and gracious request to ourselves from our brains to our bodies, to stop whatever excitatory is unnecessary. And that, you know, does it bump up the inhibitory because the excitatory is being, you know, diminished?
Thank you.
So is Carol there? She's out, huh?
Can you hear me now?
Yes.
Yes.
Okay, so in the Alexander technique, yes to what Ed said. Sometimes people confuse inhibition with psychological inhibition as opposed to neurological inhibition. And we want to, in our work, we want to make sure that we're not speaking of psychological inhibition. And I didn't know, John, if that was a piece of what you were saying. I couldn't quite tell. But by asking for a prevention of something, or for something to undo as a thought request, and getting a response from that is part of the inhibitory process in the Alexander technique. Now, I don't know, John, how that relates to what you were saying quite.
I think he said that I think he was relating to the parasympathetic nervous system, that's part of defecation, that has to be functioning well in order to defecate well. That was my sense of it.
Did we answer your question, Susan?
Yeah, I think so. I think what happens is when we're working in these different, so many of us are coming from and working in different modalities. And so then a word comes up and, you know, 3 different kind of groups are using it, similar words in very different ways. And so it can get confusing to the listener. So
Right.
Thank you for the clarification.
One other little thing, given that the pelvis is such an emotionally loaded part of the body, probably the most emotionally loaded, the psychological inhibition, you know, the part that Anna was doing such a nice job about of encouraging these women to take their time and make sure they're comfortable, and that dialogue she had with them, that she has with them at every step of the phase, what they should expect, what her hands would be doing. you know, that relates to the whole part of sort of psychologically bracing yourself against invasion. And so I just wanted to sort of bring that double meaning of that word, at least double, to the picture.
And then we're inhibiting habitual
Yeah.
behavior. It's a mindfulness thing, really, right?
Absolutely.
Yeah.
As regards the Alexander technique use of the word inhibition.
Yes.
Yes. It is a mindful, it is a thought process that is making a request to go this way, not that way. You know, don't choose the default pattern, but offer up another pattern that will work better for you.
Thank you.
Mm-hmm.
So Wilbur, you're back. You had a few different things. You want to unmute?
There you go.
Thank you.
Can you hear me? Yes. Anna and Neil, thank you for your presentation. Wonderful. I love as John said, I love the way that you sort of use the very gesticulating approach in terms of presenting and using your body to present things. There's a couple of things that you said I think are very crucial. One is when you talked about your examination in terms of doing some of it in the standing position as standing. Am I right about that? You're doing
Some is in standing, some is in
yes,
sitting. Yeah.
and yes, and also doing your treatment, which I think is very crucial and very important. And you know, you're one of the few therapists who I know who have that sort of approach. Because I recall once I was in home and we were doing a pelvic floor class course, and we were looking at things in the conventional sense, in supine with ultrasound and putting ultrasound up the vagina and looking at the behavior of muscles. And after much convincing, I persuaded my colleague, which is a very good German pelvic floor therapist, we need to examine the pelvic floor in a standing position. And when we did that, it was amazing the difference that we see in the behavior of the structures within the pelvis in a standing position as opposed to a supine position. So I think in terms of practitioners, our approach in terms of how we do our examination has to be based on when we ask people questions, where they're having the problems. Most people with pelvic floor issues don't really complain a lot about it when they're lying down. They complain about it when they're sitting and when they're walking, and when they have incontinence is when they're walking mostly and doing things and lifting things. So the perception of how we look at tissue and how we look at the behavior from a functional aspect, and this is where I'm coming from, is very important. The other thing that I'm interested in, I'd love you to comment on it, is when you talk about weakness, that the pelvic floor, we think that a lot of problems is not to weakness. I sort of have a question to ask. If it's not weakness, then it's something else, which is very interesting, which John talks about inhibition, which sort of makes sense when if we're trying to find a term to describe what is it that's really causing these things to happen. Because when we look at athletes, when we look at athletes, we have 100-meter Olympic level sprinters, hurdlers, who after giving childbirth or having a baby, have incontinence. So the strength is not maybe, because they have very strong pelvis, these people. Why are they having incontinence issues? Why are they having these pelvic floor issues? So that's one thing I'd like you to comment on, and I have something else. Yeah.
So my understanding of it is that it's tissue stiffness. So like you say, people can be in a really good condition before this birth, and then this birth may have had an episiotomy, which stiffens up the tissue, may have had a tear, which stiffens up the tissue, or may have just had like a baby present with an elbow, which stiffens up the tissue. So most women's health physios are going to come in and say, okay, can you squeeze around my finger? Can you close your pelvic floor around my finger? And some women can. Okay, great, brilliant. And some women can't. And really for a long time, it's like, okay, in the assessment goes, can you contract? No. Okay, so the assumption was made that that was because she was weak. And actually, she's not. That muscle is stiff. It's got a reduced range of motion. And you can tell that by aligning that with the postural assessment. So by looking at squat, single leg stand, walking, you can see she's got an area of the pelvis that's not mobile, that's stiffer than the rest. And then coming inside and doing that assessment, what I always do on that initial assessment is I ask everyone to take a breath in, because on the breath in, there should be this softening. And where there's a stiffness, that softening doesn't happen. So for example, somebody who's had an episiotomy, which is always on the right, I'm going to come in and then I'll ask them to take a breath in. Okay, and the left side will soften on that breath in and the right side doesn't. Stiff, stiff, stiff. And then I ask them to gently close around my finger, and it might be that one side will come up and contract nicely and the other side doesn't. And that is not because she's weak there. And then I can confirm by palpating into the tissue, which is actually one of the reasons why most of my work is actually done in this crook lying supine, is because that gives me a really good, the thing that position wise, everybody's knees are facing up. So if you have the knees out in abduction, everything's on stretch, you can't really assess this tissue. But if you have the knees up, then basically this tissue that lies in between the sit bones, you can really test it for stretch. So if she reports this and that symptom, and then we look at the body move globally, you can say, well, you know, you've got a reduced swing phase through the right leg. Okay, so you've got a positive stalk test through the right. Okay, so something's happening in the right. And then going in and having a look, okay, well, you don't soften on the in-breath on the right, and your right doesn't contract. So there is no way I can stand and say, your right is weak. It's just not, it's stiff. And then I can prove that by then feeling into the tissue. So yeah, your runners that then have a birth and they're so strong, so something is stiffened up, which then just can be released. And then all the problems go away.
Yeah, and I tend to agree with you to a certain point, yes, about the weakness aspect, because I don't think it's about weakness. I think it's about stiffening and inhibition in terms of the way the pelvis behaves. The pelvis, as I said before, and Niall can correct me if I'm wrong, it's an elastic ring, and the pelvis behaves aesthetically. And there's a lot of ligaments and muscles and everything in the pelvis, and that's the reason for that. We know how aesthetic behavior of tissue is to maintain tension. And if the tissue has the proper tension, is able to have its proper function. Once those tensions are restricted, and the tensions can be restricted from several reasons. One, it can be from inhibition, I think, which is something else is preventing neurological input to allow the tension, that aspect of the mechanism to work. But also, we have this, you talk beautifully about the unfolding aspect. Well, we know that when tissues have lost their gliding ability, because the different regions where the hyaluroner is in between the different regions of the tissue that allow for gliding, that mechanism stiffens itself. We know for a fact that inactivity, people sitting, women in developed countries who are sitting more have more pelvic issues than the person in my village from the Caribbean who was keeping walking and having kids. My mom had 16 children. She never had incontinence. Okay, you go to African countries and you go to the South America and you look at these people, they don't have the same issues that people in developed countries have. Because I think when we sit on our pelvis, what we do, we lose the ability for unfolding, because the hyaluroner within the system becomes stiffer. It loses its ability to allow the gliding to occur. And this affects the aesthetic behavior of tissue. And I think we have to the body is an intelligent design. Nature is not stupid. We can have a baby and people can go back to work right away the next day if they are in proper function. But our lifestyle has changed a lot of that, and we have to pay attention to that.
Maggie's just said there in the chat, squatting, you know, and actually Western toilets have got so much to answer for, because that deep squat, so, you know, we were looking before at that shape of the rectum and the puborectalis, and you need to let go of the puborectalis in order to straighten out that rectum and poo. So We're supposed to be pooing in the deep squat. And really, if we took ourselves into that deep squat every day, those tissues on the inside of the sit bone unfold. So we would be taking those muscles through their range of motion if we were squatting to poo. And in the Western civilization, this is fallen away. Sitting on toilets has got a lot to say. Yes, squatty potty. Yes.
And you can buy those blocks that you can put by the toilet, so you can put your
feet up.
Yeah.
And yeah.
Or I really rate those like IKEA stools, that like little IKEA stools about 6 inches high. I think they're quite good. Yeah, Maggie says there.
Folks, we are like way past time, and we want to make sure we get to our sponsors again and do a toast and talk about next week. Before we do that, yeah.
I'm sorry, super quickly before we go there, I think John just had something he wanted to contribute really quickly. Can we go to that?
Sure. John, you'll have to unmute.
Hi. So look, we're not going to do justice to this point tonight. So I think everything has been brilliant. Everything has been absolutely brilliant. The concern I have is in relation to the word stiffness. So if I do something like this and I feel let's say we call this my biceps brachii, it'll feel stiff. If I take a tissue and I'm using classic language from biomechanics and from anatomy, it's not a language I would necessarily use myself. But if I take something like this and lengthen it, if I feel it, it feels stiff. So we have to be, I would say, that we need to be very careful about the term stiffness and treating stiffness, because stiffness can be felt in tissues that are classically elongated, although they're not lengthened at all, or classically shortened, although they're not shortened at all. So that's a little bomb I'm throwing out there. And I know that myself and Dr. Galloway will be presenting fairly shortly on the Fascia Hub, and perhaps I'll get an opportunity to expand on that. But what a brilliant evening this has been. I've thoroughly enjoyed every moment. Well done, Susan and Lisa and everybody involved. It was brilliant, brilliant.
Well, and John, it's such a good point, because last week with Mariana and Leonid and Brad, it was all about, rather than finding the places to release, finding the places that to make stronger and stiffer, so that the overly tight places that are trying to compensate can release. So clearly we have hours of conversation ahead of us about all of this. It's wonderful. Neil, any last words?
Only thank you very much.
Thank you very much for having me. It's been an absolute
Thank you to Neil. Thank you to Steve. Thank you to Anna. Fabulous.
Wonderful. Thank you.
Presentations. We're gonna hear in a second from Graham. I'm gonna let you know that next week we have Dr. Ed Stiles coming on. Ed and Steve go back to 1980 something and met at Michigan State. Was it where you were both professors?
And at AOM and one of the other manual medicine organization.
And so Ed is still associated with, he's an osteopath, still associated with Michigan State, and also is concurrently professor at University of Pikeville. So that'll be next week. And Graham, over to you for sponsors, and then maybe Anna, you can close us out with another toast.
Okay, thank you, Susan. The Biotensegrity Party is organised by the Stephen M. Levin Biotensegrity Archive. We must thank our wonderful sponsors who contribute by spreading the word and also giving discounts on their products to our people who sign into the Biotensegrity Archive and the Zoom chat. So we'll start with Handspring Publishing, who've been with us right from the very beginning. They're based in Scotland, have a wide range of authors, and books suitable for manual therapy and movement professionals. And they're offering a generous discount in the Zoom chat. We also are thanking Chris Clancy's educational organisation, Embodied Biotensegrity, which provides an excellent resource for those of you looking to find out more about Biotensegrity, and there are several courses on offer there. The Biotensegrity Party is also sponsored by Artifact Pro, who produce wonderful anatomical tensegrity models, and Artifact Pro also offers a generous discount to Zoom participants. We then have thefasciahub.com, which is starting a new venture starting next week, Saturday the 28th of November, about the pelvis with several speakers. So register soon at thefasciahub.com. And finally, Integrated Biotensegrity, who spoke a few weeks ago, based in Alberta, Canada. Their one-day course from Saturday the 7th of November with Lisa Babiuk, Paul Thornley and Rachel Tudor is now on recording, so that's available also. So thank you.
And of course, Anna Crowle's Anna Crowle Physical Therapy, and Anna's also given us her free course. So thank you. All right, Anna, you're gonna take us out with a toast.
Well, thank you so much for having me, and thank you for such a lovely evening. And it's just such an honor and so wonderful to bring and share in this community. So thanks for this wonderful community.
Cheers.
Cheers.
Ahayam.